Good evening. Today is November 8th, 2021. My name is Crystal Bauer, and we are conducting an oral history interview today with Dr. Soni on her experiences as a family doctor during the COVID-19 pandemic. Could you please give confirm for the record that you are aware that this is being recorded and that you are giving your permission to do the interview? All right. Could you please give your name in full?
Ms. Emily Block Soni.
And what is your present title?
I'm the Director of Osteopathic Education. And faculty at Ascension Providence Family Medicine Residency.
And where is that located?
It is in Southeast Michigan in the Southfield and South Lyon area.
All right. So back to your education, where did you complete medical school?
I went to Michigan State University College of Osteopathic Medicine.
And where did you complete your residency?
At University Hospitals Case Western Reserve University in Cleveland.
That's a mouthful.
Yes.
So then you went back to Michigan to work after residency. Are you from there?
I actually did a fellowship after residency at Maine Dartmouth in the middle of Maine. I did an osteopathic manipulation fellowship.
Oh, wow. Okay. Well, could you kind of give a little bit of an overview of your current position and what you do on a daily basis?
Yeah, so I'm faculty in a residency that has 27 residents, so 9 each year. I'm also the Director of Osteopathic Education. So I work mostly in the outpatient setting, but I do still deliver babies. So I get to have that joy in my life. And then I also work a few weeks out of the year in inpatient medicine. I run didactics for the residents, specifically, I can do didactics in anything, but specifically I'm most interested in teaching them osteopathic manipulation and practices and principles.
Wow, that's a lot. Well, could you tell us a little bit about the types of patients you treat in your program, who they are, and kind of the buildup of the geographic location that you're at?
Sure. So we're located in Southeast Michigan. We have 2 clinic sites. Our larger clinic site is in Southfield, Michigan. That is primarily an urban setting, very underserved area, mostly Black African American patients. I am only there about 1 day every week or every other week doing just osteopathic manipulation, but that's the population that I serve when I do inpatient medicine.
Okay.
And then my clinic site is out in South Lyon, Michigan, which is about 45 minutes west of Southfield. And we're more of a suburban setting now. It was a very rural clinic when we started, 60 years ago here. I wasn't there 60 years ago, but I'm told it was very rural. It's been moving more towards a suburban. Our clinic population here in South Lyon is very elderly. We have a lot of 90-year-olds, 80-year-olds, 70-year-olds, and they've been greatly impacted by just the isolation of COVID, and then just losing a lot of friends through this pandemic. So that's about it for our.
So that's actually really interesting because it sounds like the clinics have such a different, population in general. You're kind of exposed to 2 very different populations.
And our population here is mostly Caucasian. I should say that too. More elderly, more Caucasian here, and then generally more middle-aged in Southfield.
Okay. So thinking back to the onset of COVID-19 in 2020, could you describe how it first impacted your area and your locations?
Yes, I have a lot to say here, so
Sure.
bear with me.
Yeah.
So Southeast Michigan was one of the first hotspots. So the Detroit area was was hit really hard back in March and April of 2020. We went March 1st, around March 1st, we had 1 COVID positive patient. Granted, we weren't testing everybody, But within a couple of weeks at our two main hospital sites, so we have Southfield and Novi, we had over 350 COVID positive patients, or what we called people under investigation. It was taking about 10 days for the tests to come back. So when somebody came in with a disease that looked like COVID, they got called a PUI and placed in the COVID units. That was very strongly hit. So I'm going to talk a lot about that. But then on the office side of things, we had actually just started to implement about December of 2019. We put into place the ability for us to do virtual visits. And we had done a couple, and we were like, okay, we can kind of start to do this. And then March of 2020 came, and we're like, okay, everything is virtual. So we pretty much switched to completely virtual care, and we were able to do that pretty seamlessly because we had already like trained in it and tried it out a couple of times. So that was pretty swift. So in the hospital, when we got hit initially with all of this, we, like everyone else, was very short supply in our PPE. The COVID tests, like I said, were taking sometimes 2 weeks to come back. So the hospital administration really acted very quickly to put emergency plans into place. What they did at our hospital was cohorted the floors. So they said, you are the physician for this floor. You and I had a colleague that did half the floor, I did the other half, and we had 2 senior residents that were with us during that time. So that was about 10 to 15 patients per day that I would cover. Our unit, our family medicine department, we volunteered to be deployed to these cohort units. And so I was there from March 30th to April 8th or 9th. And that was really the peak of our involvement in this COVID, that first COVID wave. So we worked in 12-hour shifts. We did 3 days on, 3 days off, 3 days on, and then we stopped. So I was really only there for 6 total days. During that time, we had 1 N95 mask that we would use per shift, which, from what I was hearing from the other hospitals, which was a lot better. Like, we got one for the whole day. We didn't have to use it for a week, but you would put that on in the morning and really not take it off the whole day unless you were eating. We rounded on all the patients in the morning. We would put on our gloves, our shoes, our gowns, our bouffant caps, our face shield. We would put on double gloves. And then we would start with the people that were the least likely, that were still PUIs. They were the least likely to have COVID, so that we wouldn't spread it from room to room. We'd remove just our outer layer of gloves because we didn't have enough of everything else to change. Put on clean gloves and go to the next room. Usually when we would round in the morning, it would involve stabilizing 1 to 3 patients that were on the verge of intubation or are very ill. I would do ABGs because we were limited in our phlebotomists and our ability to do ABGs. Respiratory therapists couldn't do them because they were elsewhere. I titrated up the oxygen levels because the nurses were really trying to also limit their time in the rooms. We would then go write our notes, eat lunch, and then round on the patients again in the evening. If we consulted any specialists because of a cardiac side effect of the COVID or something else going on, they would stay outside of the room and call the patient and rely really on our physical exam and our ability to talk to the patient so that they wouldn't have to waste the PPE to go in the room. And then there was the nurses that they were really the ones that risked exposure the most, and they were absolutely incredible. But I did try to coordinate with them if I was going in the room to help the patients to the bathroom or whatever they needed, so the nurses wouldn't have to make another trip. Thankfully, we have not had to go back to that cohorted level of care again. Michigan has been very strong in its response to COVID. Our governor really has had mask mandates early, has really tried hard to get the word on the vaccine out. And so we haven't had to go back to that. And I really hope we never have to again. On the floor where I served, of the patients I cared for with my partner, we lost 11 patients in those 6 days, which is really more death than I have ever seen. And I have not seen a disease sweep through communities like this one. the patients I cared for. I had one patient that lost 2 cousins, an aunt, and 3 friends to COVID before getting hospitalized. And then while she was there, her mother and her aunt were also on a vent in the ICU. One day I had a hospital employee, because no one was really allowed in the rooms, but there was a hospital employee who worked downstairs in the kitchens. He came up because his mother-in-law was there and she had gotten off of the vent. So she had been intubated and now she was on my floor. And she had lost, while she was vented, her mother and sister. And so he came up to help me tell her that this had happened while she was intubated. We put up her family on FaceTime to deliver the news, and her grief was like so sudden, and she was just alone in this room where she couldn't get the support that you would normally get in that situation. And it was heartbreaking. During my second set of 3 days I was there, the more time had passed since we knew that this had happened in our community. And so many of the people I was taking care of during the second 3 days that I was there were healthcare workers or people that had been cleaning the hospital, nurses, just anyone that had been exposed either at my hospital or another one. At that time, we had 2 of our own infectious disease doctors and an internal medicine doctor that were intubated in the ICU. And the day before, there's another caller came in. I don't know. Okay. The day before I started my second shift there, a resident that was my age had died in a nearby hospital. So it was a really terrifying time. As I was taking care of these patients, though, they were unbelievably grateful, even though we knew so very little and we really only had guesses at what might be helpful for them. We were using steroids at that time, really not knowing if they'd be helpful or not. And then that was when we were still using like Plaquenil and azithromycin and just like crossing our fingers that that would be helpful. And then as an osteopath, I offered all of my patients that were well enough and with it enough to consent, I offered them osteopathic manipulation. During the flu epidemic in 1918, the osteopathic hospitals would have all of the physicians go around and do OMT rounds on their patients. And they reported a lower morbidity and mortality rate in their hospitals. And so I was like, well, it is my time to do this. So there's really only one technique that I did on all of my patients, and that was the pedal pump. Most of the other techniques we do really require a lot of prolonged close exposure. And so I was too scared to do that. But with the pedal pump, I'm able to stand at the foot of the bed 6 feet away from the patient and put my hands on their, not from the patient, but from the patient's mouth, from where the COVID is coming from. So I stood at their feet and I would push on their feet in this rhythmic pattern. It would kind of makes their whole body move. This has been shown to increase lymphatic flow throughout the body and promotes the body's natural immune response. My patients really looked forward to this. When I walked in the room, they got ready in the bed. They put their feet out. They're like, okay, where's my daily jiggle? Some of them called it. And so they, after that movement, because many of them were so sick, they were just laying in bed motionless. Just that motion, that movement of me doing that for about 2 minutes really helped them feel better. They were told me they felt better and they could breathe better. There was one nurse that I had that was teetering on the edge of needing intubation for a few days. Her ABG was showing oxygen levels in the 50s and low 60s. And so I used this technique and a few others on her. And I told her to lay prone, which was not something that we were doing. We didn't know to lay prone. I remember arguing with a respiratory therapist we were trying to intubate this patient, but we didn't have the stuff that we needed. We were out of propofol. We were out of any sedating thing. So I was like prone that patient. I heard, some news from somewhere that would be helpful. And they're like, what are you talking about? And they didn't really argue with me, but it was just this new thing that nobody was doing at the time. So told this patient to lay prone. And anyway, after I finished my 3 days with her, my colleague came on and she said, I really appreciate Dr. Soni because I think that's the only reason I didn't get intubated. So I
Wow.
appreciated that, and hopefully made a difference for her.
Yeah.
The days were really long. At lunch, local restaurants brought food. So we would go, and the 3 other doctors I was with, we'd have our lunch break, mask break. So only 15 minutes we took off our masks. And then at 5 p.m. every day, my team would do what I call wellness rounds. The halls were eerily quiet because the doors were closed. We were on a unit where there were no windows out, so we couldn't see into the patient's rooms. They couldn't see out. And there are no visitors at all allowed in the hospital. So my team would go down and do lunges and squats and yoga and just have about 10 minutes of wellness near the end of the day. And then we would stay until 7 p.m., go home. At home, I took off my shoes in the garage, threw my clothes immediately in a bag and showered, put on a mask, and then put my 2 and 5-year-old to bed and got up in the morning before they were awake, and just hoped every day that I would not expose them or my immunocompromised husband. So thankfully we got out of it without any COVID so far. So masking and PPE does work. So that's my very long answer to that question.
No, that's wonderful. Thank you so much for sharing and having so much detail from last year. That's very powerful. So thinking in terms of the present, what unique challenges do you feel like your program faces now with COVID-19, and kind of how has that changed from the challenges you had last year?
So ongoing challenges from COVID-19 mean we may have to completely change our curriculum from being an in-person to virtual, depending on the COVID numbers in the area and the positivity rates. And so we've gone from, hey, we're actually going to meet in person this week, and then finding out later that we can't. And so it means changing our teaching style on a dime and trying to get these residents the teaching that they need without always being able to do it the way that we feel comfortable doing it.
Sure.
So we've done a lot of on the dime changes. And I'm sure that's not unique to my program at all. We've now are starting to do more things in person, which has been very good for morale and for teaching, I think. We've also struggled with how do we teach and promote resiliency in our residents as they go through this really, residency without COVID is a hard thing. It's
Sure.
like, it's kind of it's not like going to war, but it feels like you're going through this really hard thing that you struggle with, and there's this cohort that you go through it with. And now with COVID on top of that, our residents are really seeing a lot of really hard things and experiencing it on a daily basis. So focusing on wellness has been, we've really tried hard to do that throughout this pandemic. Initially, that meant that our behavioral health director would personally reach out to each of us, faculty and residents, to check in. Now we're able to gather and be in the same place and have more conversations about what we've all gone through as a program and a country through this whole thing. So, yeah.
You mentioned this cohort of residents has really been hit with a lot. Would you say their inability to be in person all the time has impacted, their ability to bond with one another? Has it impacted like that togetherness at all, would you say? Or
I think some ways they've bonded more because when you go through hard things together, you bond really well. But they've been limited in their social interactions the way that, I was able to do when I went to residency.
Yeah.
And so that kind of, and maybe I'm wrong, maybe they're all getting together much more than I expect, but at least initially in spring of 2020, they were really feeling the stress of not being able to be with one another. I
Sure.
think much less so now. Um, so.
Could you describe the vaccine rollout initially in your area and kind of your staff and patients' reception to the vaccine?
Oh, yes. Okay, so our our hospital started vaccinating employees December 16th, 2020. I got to be on the first day of vaccination, so that was pretty neat. We kind of
Yeah.
sat in this room full of respiratory therapists and doctors and nurses, and as we waited to see if we'd have a reaction, and just kind of had this great conversation about like, what does this mean? Like, this brings us so much hope,
Yeah.
and so much relief from the
Yeah.
year that we had. By late January, we had set up a clinic site, a vaccine clinic site, which it was very far for my patients here in South Lyon. So it was about an hour drive for my population here. It was much closer for Southfield, but our Southfield population has a lot of transportation issues. So that was not a place that public transportation went easily. And so they were very limited in their ability to get the vaccine. Our folks here, we're calling up a 90-year-old and saying, can you drive an hour to get this vaccine and then drive back? It was really very challenging. But what my clinic did is every day at the end of the day, they would say, these are the vaccine slots that did not get filled. And my staff, mostly my nurse practitioner and my medical director and a couple others, would be on the phone every night until 10 o'clock, just like, hey, we do have a slot. Can you go tomorrow? And we would do everything that we could to get all of the slots filled so we wouldn't be wasting any doses. And I had done that a couple of times. It was a very, very strange experience to call someone at 9:30 at night and say, hey, what you doing tomorrow? You're gonna go get this vaccine. And many times it was met with, yes, I've been trying so hard to get it. So there was that. Our medical director, Dr. Stacy Bartel, lobbied from very, very early on to get this clinic sites closer to our spot. She's been an advocate for pushing vaccines at primary care locations because we as family doctors are uniquely qualified to kind of get this vaccine out. So she was able to get the vaccine kind of here before it was anywhere else, which was nice because a lot of our patients that couldn't drive out there were also having trouble finding vaccine appointments through the health department or through the pharmacies when it was early on. So they came here initially very eager. So we got that population that was excited to have this vaccine, knew what it meant, rolled up their sleeves and did their part. We still have around 20% of our population now that is not vaccinated and they're not willing to get vaccinated. So this has been for many different reasons. Most of the time it's because of some misinformation or conspiracy theory that they've heard of. I've had some pretty ugly conversations. Conversations turn pretty ugly as I try to convince them to get the shot. Our staff here, they mostly also jumped on board and got vaccinated. Our vaccine mandate came into effect for Ascension, which is the bigger organization I work with. Earlier this month, I think it was like the second, you had to be vaccinated by the second. And we did lose, I think, 2 staff members at my clinic that did not want to get vaccinated, and their their religious exemption was not accepted. So we are very short-staffed now because we were short-staffed before, but we are now extremely short-staffed.
Sure, sure. And I'm assuming you, since the vaccine rollout for the younger age group, the 5 to 11, has that had any impact? Do you see clients at that age?
But we
Has
we
it?
definitely have a patient population that's that age. It's probably 5%.
Okay.
We have like a 5% pediatric population. We have asked for, ordered the vaccine, but we do not yet have it. I mean, it was last Monday it was approved, or Tuesday.
Yes. Yes.
So right now, in our area, vaccines are pretty readily available, not at the local pharmacies. So the eager parents that are really wanting to get their kid vaccinated now, we're able to direct them and they can get a vaccine appointment. The most I've had someone have to wait is 2 weeks at this point. So that's been pretty effective rollout, I think.
Oh yeah, for sure. So what skills do you feel like family doctors need to continue to fight this pandemic? And how do you see medical and residency programs adapting to help their students and residents meet these demands?
Being a family doctor over the last 20 months has meant really changing and learning medicine on the fly and learning a lot about public health that I certainly didn't learn as a resident. I mean, I learned about public health as a resident, but this is like a crash course in public health. Um, with the science changing so rapidly, it's really important to promote that lifelong learning skill. Something that I learned last month about COVID is probably not true anymore. And so every
Right.
time I round at the hospital, I'm like, hey guys, what have you learned from the infectious disease doctors that's new? This is what I'm reading. What are we doing in the hospital? And really
Yeah.
learning how fast medicine can change. And I was doing some reading about an old um, cardiologist who's still alive, who was like the first to give someone a beta blocker who had heart failure, and the first to describe hypertrophic cardiomyopathy. And unfortunately, I can't think of his name right now. But I was reflecting on the time where he was practicing 40, 50 years ago, and they didn't know what beta blockers were. And there was
Yeah.
so much about medicine that was unknown, and there's so much now about medicine that feels very known and solid and not changing. And this pandemic has taught my residents and me that that's not true, that we are learning and
Right.
changing so much with medicine in general every day. um, the other thing about this pandemic is the education piece. Really trying to We're mounting an anti-misinformation campaign in the middle of all of this while we're dealing with very sick patients in the hospital, and then coming to the clinic where people are like, COVID's not real, and what do you mean
Yeah.
there's people dying? That's not a real thing. And we're like, no, we,
Yeah.
we saw it like yesterday. We were there. Like, it's
Yeah.
happening. And so teaching our residents effective communication skills, how to educate, motivate, motivational interviewing their patients to get these vaccines. So having a strong behavioral health program to foster those skills, and also foster the skills of self-care and resilience as you're going through this trauma every day.
Yeah.
And all the things that we're facing. And then the other thing that we really need to focus on teaching our family doctor residents is how to advocate for their patients and communities at a government level, at a community health level. So we're trying to get our residents involved in the hospital system. So why don't you join a committee at the hospital so you can see how these decisions are made? But we do every year we go lobby at the Michigan State Capitol for healthcare related issues. So we're trying to foster those skills so that we can have a bigger voice in the surrounding government and area.
That's great. What have you learned through this pandemic?
Yeah, so I don't think I can fully grasp how much this pandemic has yet taught me and changed me. Um, I've certainly learned I had respect for all doctors and nurses before, but I have learned a new respect for the ER and ICU doctors and the nurses that are, and the respiratory therapists and everybody else who's
Yeah.
really in this every day in the hospital. I can run away to my clinic, which is a nice reprieve from the hospital. I've learned a lot about humanity and how at the beginning it was just really amazing how humanity like pulled together and really did the things that they needed to do to protect and support each other. And then I've seen really this misinformation campaign and how when that takes root in the community, it's so easy to sway people to believe what you are selling, the snake oil you're selling, when they're afraid. And people have been afraid for a long time, and how that misinformation can end a life. And it's really, really sad.
Yeah.
And then I've really learned a lot about public health, and the public health measures that can be taken that by law. I'm learning all about this law. It's the laws and the power of the government, and really how much society has to sacrifice for the public health. And that's, something I'd read about, but not experienced until this.
You've mentioned this briefly before, but what do you feel like your residents have learned through this?
I think they've also seen that misinformation, and how people can be in denial about reality and how frustrating that is. I've seen them um, learn things very quickly, learn how keep up with changing medicine. I've seen them adapt very quickly to, we've never done virtual and telephone medicine before. Let's learn that really quick. And the residents are like, sure, that seems like a challenge I can do. And many of them are very computer savvy and it's no big deal. And they're FaceTiming and, doing not virtual visits, but hanging out with their friends virtually all the time. So it's pretty easy for them to adapt to those things. Yeah, it's hard.
It is, yeah. You've mentioned, your respect for ER staff, but who are the people you've worked with most closely during the pandemic that have impressed you? And were some of these established professional relationships, or did you form new relationships through this that really impacted you?
Initially, there was a infectious disease doctor, Dr. Husarski. He was the one that was at Southfield with us, and he would round on every floor because every floor was COVID. Every day, he was there for 15, 16, 17, 18 hours a day. I don't know how that man was still standing.
Oh my
His
gosh.
colleagues were literally intubated in the ICU, so there was no one else. Like, it was crazy. So he would come every day and I'd sit down with him and I'd chat with him. And I was just, he was very knowledgeable, and he would just reflect like, I don't know. I don't know if steroids are going to be helpful. I don't know if Plaquenil is going to be helpful, and he was very real and um, obviously cared very much about everything that was going on and was willing to sit and educate me. So I appreciated that so much. Um, our medical director, and so I hadn't really had a relationship with him before, but now every time I see him in the hallway, I'm like, hey, dude. Another really person that impressed me early on was Dr. Sorcer, who's a gastroenterologist, and he volunteered to be cohorted to the floors because he's like, I can't do scopes. I basically can't do anything outpatient. I'm a trained internal medicine doctor. I'm here. And he also put in like crazy hours, and
Wow.
that was really impressive. Um, our medical director, who I had a very good relationship with before, and just has, I'm professionally very impressed by her, Dr. Bartel. She's just been such a strong advocate for our patients and for our clinic throughout this whole thing. I mentioned that she was really the one that got our site to get the vaccine early on. She's
Yeah.
been really instrumental in all of that. We are currently still vaccinating a higher percentage of people on of the vaccines that Providence Hospital is giving out. Our clinic is giving out most of them, like a higher percentage
Wow.
than any other clinic. So that's definitely because of her. So
That's wonderful.
yeah. She's also been really good at changing protocols as like, hey, now we're doing vaccine boosters. Let's get a protocol in
Yeah.
place immediately to get that rolling. And she's been really a great innovator and effective leader throughout this whole thing. So um,
That's important.
Mhm.
So looking to the future, what is your sense of where family medicine is going?
So I'm
Big
about,
question.
yeah, I know, big question. I'm about 10 years into my career, and I think I'm still very much in the weeds. Um,
Okay.
I remember feeling as a resident like I'm never going to understand the bigger picture. Like I'm focused on this potassium right now, and now I'm like, oh, the
Yeah.
big picture. I feel like there's going to be a moment in the future where I look down and I'm like, oh yeah, this is the big picture of family medicine and where we were and where we're going. I certainly, uh, I'm looking forward to having that bird's eye view. I have a grasp now of like all these changes that are happening because family medicine and the payment model and like
Yes.
quality improvement measures and performance and value-based care, and we're part of CPC plus and all these things. I'm sure I'm forgetting something. But anyway, uh, what we need to do as family docs is really advocate for ourselves so that in the future, family medicine will be better reimbursed for what we do. Um, right now, we certainly have, I mean, maybe not pandemic now, but 2019 now, we had some of the highest burnout rates in medicine. Um, so we have less time with our patients to do more work for them. As a doctor mom, I rush home every day at the end of work so that I can have time with my family, put my kids to bed, and then I'm charting and responding to messages and things on the portal. So personally, I'm concerned about the scope of family medicine getting narrower. I see it happening. I see less pediatric patients coming in. I see less pregnant patients coming in. And so as a family doc that still does obstetrics, I'm really like, please,
Yeah.
we need to keep this as part of our scope. My my residents, that they're not very interested in obstetrics, and I try and make them interested, and they're just not. And so they're not learning it because they're not interested, and then they go out and they don't practice it. And so I'm worried about family medicine kind of losing these skills that we've had for so long.
Yeah.
I know this is different, in Maine where I did my 1 year fellowship. They were an unopposed program. They were very involved in their obstetric program. They saw a lot of their OB patients. So I'm hoping that there's other areas that are in more rural, not not my urban areas, um, that have more OB numbers and they can keep it going. So here's that.
Are there any views on important issues in the specialty related to COVID-19 that we've not addressed that you want to share with us? Anything we're leaving out?
Addressed everything. I think I've said all the things.
You said a lot in great detail, which is wonderful. It's great to have those thoughts. Any thoughts overall that you would like to add that we haven't covered? This is your chance to be a part of history. So anything left you'd like to share related to family medicine?
I really appreciate. I'm just so grateful for this opportunity. I'm really glad you guys are doing this. One of my favorite things was a oral history thing like this that my great uncle was in Pearl Harbor, um, and he before he passed away was able to do one of these, and listening to that audio recording was really neat. And so I was thinking about him as I was preparing for this, and I'm just really really glad you guys are doing this. I feel a lot of pride about being a family doc. At the beginning of this, when my family was very nervous about everything, I was very nervous about everything. I said, but as a family medicine person, like, I can do this. I know how to take care of these patients, the scope of my practice. I'm uniquely qualified to deal with these patients, inpatient and outpatient. So I'm the one. I didn't necessarily sign up for this, but I'm the one. And it's been a journey for sure.
Well, Emily, thank you for all your amazing work as a doctor, and thank you so much for doing this interview. We really appreciate all of this.
Thank you so much. I really appreciate you.